Hello everyone. In this video of CNS, I would like to discuss about the following questions. Number 1, subarachnoid hemorrhage. Number 2, infections of the brain, that is acute meningitis, HSV encephalitis, neurosyphilis, prion disease, and a neurodegenerative or a demyelinating disorder, that is multiple sclerosis. First, let us start with subarachnoid hemorrhage. Remember, we will discuss under the following headings. Number 1, what is the definition? Subarachnoid hemorrhage means any hemorrhage which occurs beyond the layer of arachnoid. Sub means below the layer of arachnoid. Coming to etiology, remember, trauma is the most common cause of subarachnoid hemorrhage overall. But coming to the other cause other than trauma, it is because of the rupture of the berry aneurysm, also called as a saccular aneurysm. What do you mean by saccular aneurysm? It is nothing else but an abnormal dilatation of the circle of Willis. Circle of Willis is the primary blood supply to the brain. Remember, saccular aneurysm is the most common type of intracranial aneurysm. Okay, other type of aneurysms are mycotic, traumatic, and dissecting type of aneurysm. Other than this trauma, this hemorrhage may occur because of any vascular malformation, bleeding disorders, and any brain tumors. And just remember, this is mainly found in saccular aneurysm is found in 2% of the population. As far as pathogenesis is concerned, remember, the saccular aneurysm, why it happens? Why? Because there is absence of smooth muscle and intimal elastic lamina. We have tunica intima, right? Tunica intima media. There is absence of smooth muscle in the media, as well as there is absence of elastic fibers in the intima. As a result, there will be abnormal permanent dilatation. It is not temporary, it's a permanent dilatation of the blood vessel walls. Okay, fine. It is also genetically involved. For example, in Mendelian disorders like autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease, you have to remember two important chromosome children. One is chromosome number 16 and another is chromosome number 4, which will cause for the proteins, okay, that is called as PKD1 and PKD2. Okay, and remember, that is saccular aneurysm is one of the extra renal manifestations of the autosomal polycystic kidney disease. Other extra renal manifestation is liver cyst. Okay, and Ehlers-Danlos syndrome, neurofibromatosis, and next is what we call as Marfan syndrome. Okay, or any other fibromuscular dysplasia. Coming to the morphology, remember, once you look the gross, there will be an unruptured circular aneurysm will be there, which is having a thin wall, which will be usually protruded out along the circle of the Willis, and usually measures 2 to 3 centimeter in diameter. It usually have a bright red and shiny surface with a thin translucent wall. And of course, you can see atheromatous plaques and calcification that is responsible, which is the initiating factor for this, saccular aneurysm. And on histopathological examination, you can see smooth muscle and intimal elastic lamina will be absent. Clinical features, there will be thunderclap headache. That is, the patient will complain and says, the worst headache I have ever heard. Okay, thunderclap headache is the characteristic clinical presentation of the subarachnoid hemorrhage. Subarachnoid hemorrhage means always trauma. First exclude trauma, then only you have to search for other causes. Okay, fine. You can see the picture of this. You can see a saccular aneurysm, a dilatation of the circle of the Willis, and actually mainly the saccular aneurysm, the dilatation occurs in the anterior communicating artery of the circular Willis. Okay, fine. Once that is done, let us go for the infections. The most commonest infection that we will encounter is what we call as acute pyogenic or bacterial meningitis. First, coming into what do we mean by meningitis, means inflammation of the meningeal layer of the brain. Coming to the etiology, we have Escherichia coli, okay, and group B streptococci in case of neonates, because in each age group the causative organisms are different. Then we have Streptococcus pneumonia and the Listeria in elderly. But if they ask you what is the most common cause of meningitis, your answer should be Streptococcus pneumonia. Unless in neonates, you can go for group B streptococci like Streptococcus agalactiae, as well as in case of Escherichia coli. Then Neisseria meningitis, Haemophilus influenza. Okay, fine. And remember, this Neisseria meningitis is actually associated with a condition called Waterhouse-Friderichsen syndrome, in which there will be adrenal hemorrhage along with the septicemia. Okay, I think you would have already come across this terminology in the chapter shock or hemodynamics. Okay, fine. Coming into the morphology, so when they ask about meningitis, you can elaborate about the causative organism and everything, but as far as pathology is concerned, morphology and histopathology is important. In morphology, you can see an exudate will be seen. Okay, which is evident with the leptomeninges over the surface of the brain. You can see the meningeal vessels will be more prominent. Okay, and sometimes in case of what to say, Haemophilus influenza meningitis, this exudate will be usually basal, whereas in case of pneumococcal meningitis, it will be mainly over the convex cities, that is near the superior and inferior sagittal sinuses. Okay. And remember, it may also affect the ventricles. Okay, when the ventricles is affected, the ventricles will be filled with the pus. Coming to microscopic examination, very easy. Meningitis means inflammation. It is an acute inflammation. So what are the cells which will come? It is neutrophils, which will fill the subarachnoid space, and the leptomeningeal blood vessels will be invaded by the organism as well as the neutrophils. And Gram stain will reveals variable number of bacteria. There will be vasculitis, thrombus formation, and death occurs. Fine. Okay. And some cases there will be what enlargement of the ventricular system of the brain, which we call as hydrocephalus. Fine. Once that is done, let us go for the next question. That is what we call it as neurosyphilis. Neurosyphilis is a very commonly asked question, especially the morphology. Just write these points, that's enough. Okay, what do you mean by neurosyphilis? Remember, first of all, neurosyphilis is actually, this is the third question, okay? Neurosyphilis is another different question. It is actually the manifestation of the tertiary stage of the syphilis, okay? We have primary stage, secondary stage, and the tertiary stage of syphilis. Of course, we have latent syphilis, early latent, okay? Latent syphilis is there, congenital syphilis is there, but here we are mainly discussing about tertiary syphilis, which has two important manifestations. One is neurological manifestation, another one is what we call as the cardiovascular manifestation. As far as the neurological manifestation is concerned, we have neurosyphilis, okay, which is actually one of the important and which is a deadly manifestation of the tertiary stage of syphilis. And remember, it only occurs in an untreated infection. Okay, we have not detected the patient in the primary stage, we have not detected the patient in the secondary stage, the patient has gone for the tertiary stage, then only we will have something called as neurosyphilis. Okay, fine. As far as neurosyphilis is concerned, let us see what are the clinical features or the clinical manifestations of this. Because of the impaired cell mediated immunity, okay, there will be what to say, mainly which affects the central nervous system, that is we have the brain and spinal cord, right? And they will mainly manifest as tabes dorsalis, which is actually one of the spinal cord manifestation. And next one is what we call as paratic disease or tabe paris. Okay, fine. So coming into the three important forms of neurosyphilis. Number one is actually called as meningovascular neurosyphilis. Number two is actually called as paratic neurosyphilis. And number three is called as tabes dorsalis. So it is meningovascular. That means it involves the meninges of the brain along with the vascular structures of the brain. And remember, the most important arteries which are involved are actually called as the end artery. What do you mean by end arteries? The arteries which do not have any anastomosis with any other artery. These arteries are called as the end artery. Okay, there will be end arteritis. End arteritis is one of the histopathological feature of, okay, end arteritis is one of the characteristic hallmark feature of syphilis. Okay, so and that too Hubner's artery. Hubner's artery is actually one of the important artery that mainly supplies our internal capsule. Okay, so there will be what to say, Hubner arteritis, and there will be a inflammatory reaction. Here neutrophils and lymphocytes does not play a role. Remember, in syphilis always it is plasma cells invasion. Plasma cells will undergo invasion into the what to say meninges, and this is actually characteristic producing what we call as gummatous lesion, gamma. Okay, this is called as syphilitic gammas. Coming into the second feature, that is paratic neurosyphilis. Here actually what will happen? Paratic, so parasis. That means it is going to mainly affect the cerebral cortex. Here there will be mood alterations, severe dementia, and this is actually called as GPI. What is GPI? Okay, that is called general paralysis of insane. Okay, general paralysis of insane. And here histopathologically we can see proliferation of microglia, gliosis, and iron deposits will be there, which can be demonstrated by the Pearl's Prussian blue reaction. Coming into tabes dorsalis, which is mainly because of the tabes dorsalis. Okay, this is actually mainly because of the dorsal root. Dorsal root of the spinal cord is always sensory. So there will be what to say, loss of pain, sensation. Okay, and that is actually there will be what to say, joint damage. We call it the charpal joints. Okay, ataxia will be there. There will be absence of deep tendon reflex on microscopic examination. There will be atrophy of the dorsal column of the spinal cord. Remember, usually the syphilitic organisms, okay, that is the Treponema pallidum, cannot be demonstrated in any spinal cord lesions. So this is actually the tabes dorsalis. Once that is done, we will go for HSV encephalitis. Okay, HSV encephalitis. Okay. And just an important point, okay, just for a purpose of MCQ, in HIV, we will have a characteristic histopathological finding called microglial nodules. Okay, you may get this as an MCQ. That's why I'm just mentioning it. In HIV, you have something called as microglial nodules, which is actually a HPV feature. Coming in HSV encephalitis. Herpes simplex virus is a very notorious virus. We have HSV1, we have HSV2. Remember, HSV2 has mainly genital predilection, whereas HSV1 has mainly CNS and cutaneous features. So HSV1 causes encephalitis, which will characterize present with weakness, lethargy, ataxia, and seizures. Okay, and this will occur over a period of 4 to 6 weeks. What is the causative organism? HSV1. Okay. See, you can see the picture. There are two important areas of the brain has been involved here. That is actually the frontal and temporal lobes. Remember, HSV means always frontal and temporal. Out of frontal and temporal, which has more involvement, answer is temporal lobe. Okay, fine. So the encephalitis actually mainly involves the temporal lobe. Okay, and then goes to the frontal lobes, and it will be usually hemorrhagic and the necrotizing lesions will be there. And histopathologically, the characteristic inclusion bodies which are found in HSV is actually called as Cowdry type A inclusion bodies, which are nothing else but an intranuclear inclusion body. In the first video, I have told you we have intranuclear and intracytoplasmic inclusion bodies. Here we have actually called as intranuclear inclusion body, that is called Cowdry type A inclusion bodies. Okay, fine. And there will be more diffuse involvement of the brain. Fine. Okay, that's done. So that's about HSV encephalitis. When they ask about HSV encephalitis, you can write about the organism. You can write about the features of the organism. That everything comes from microbiology. As far as pathology is concerned, the morphology is important. The histopathological features is important. Okay, and just a few 2-3 points about clinical features. Okay. Once that is done, let us discuss about a very important question, that is a demyelinating disease of the central nervous system. What do you mean by demyelinating disease of the central nervous system? Demyelinating disease of the CNS are nothing else but they are the conditions which is characterized by damage to the myelin sheath. Only myelin is affected. Axons, neurons are normal. Okay, fine. And the first and foremost condition is multiple sclerosis, commonly called as MS. It is, remember, it is first point. MS is autoimmune. It is AI. Okay, it is an autoimmune demyelinating disorder characterized by distinct episodes of neurological deficits. Okay, which are separated in time and attributable to patchy white matter lesions that are separated in space. What does this statement actually mean? You will study in medicine. Okay, we have different phases of multiple sclerosis. Okay, we have different variants of multiple sclerosis: relapsing variant, primary variant, secondary variant. Okay, I am not going to such things. Just remember, it is a demyelinating disorder of the central nervous system. Axons are intact, okay, which will occur over a time. It is an autoimmune condition. That's enough. Remember, its incidence is around 1 in 1,000 persons. We have relapsing and remitting episodes of variable duration. Remember, whenever in CNS, whenever you come across a clinical case scenario in which the weakness or the neurological deficit has a remitting and a relapsing period of or pattern, the first diagnosis which comes into your mind is MS or multiple sclerosis. Remember, let us go for the pathogenesis. It is an autoimmune response. It is an autoimmune response. The antibodies are directed against myelin sheath of central nervous system. Okay, fine. And remember, what are the mechanism? Okay, remember we have some environmental factors, genetic factors, and some immunological mechanisms. So first is genetic factors. Because of some mutation of interleukin 2 and interleukin 7, or what to say, these antibodies may be produced because of some environmental variations. Okay, geographic features, for example, low levels of vitamin D. Okay, next is immune mechanisms, which is the one which I am going to discuss in detail. That is, we have T helper 1 and T helper 17 T cells. This actually will react against the myelin antigens. As you have studied in chapter 6 immune system, this T helper 1 and T helper 17 will activate what we call the interferon gamma. This interferon gamma will activate the macrophages that is responsible for what to say damage of the myelin sheath. Okay, fine. So coming into the morphology, I told you it is going to mainly affect the myelin sheath of the central nervous system. That is, it is actually a white matter disease. Almost the grey matter is almost intact. Fine. And here we have sclerosis. What do you mean by sclerosis? That means the lesions will be firmer. Okay, the lesions will be firmer. That means it appears to be a little bit thick than the surrounding normal neuronal tissue. That is why we use the term sclerosis here. Okay, and we can see well circumscribed Okay, great and irregularly shaped plaques can be seen. We can also appreciate area of demyelinations will be present, and these plaques are most commonly seen in the corpus callosum and ventricles of the brain, followed by brainstem. And microscopically, what we can see the myelin breakdown with the abundant foamy macrophages. That is the macrophages will be consuming this myelin sheath, which will finally appear like a foamy macrophages, like we have, which happens in cases of any lipid or storage disorders. Okay, in lipid storage disorders, the excess fat will be consumed by the macrophages, and finally the macrophages will be appearing like what we call as the foamy macrophages. Okay, fine. Yes, and remember, as far as histopathological examination is concerned, I told you axons are relatively preserved. Okay, and reactive gliosis. Okay, reactive gliosis is one of the most important features of multiple sclerosis. And as far as clinical features is concerned, there will be wide spectrum of clinical features. Optic neuritis is one of the most important features. Okay, cranial nerve involvement, there is ataxia, nystagmus, ophthalmoplegia. Okay, motor and sensory impairment, autonomic function is impaired, that is there will be loss of bladder control, spasticity, everything is present. And remember a very, very important finding: in CSF examination, there will be protein will be elevated. There will be pleocytosis, that means different morphologies of the cells. IgG levels will be increased. We can see some special IgG band. Okay, in electrophoresis, we can see some special IgG bands. Okay, in electrophoresis. Okay, these are some of the important features of multiple sclerosis. Okay, and with this, we finishes what we called as our multiple sclerosis, and then we will be going to another important condition, that is what we called as prion diseases. Okay, prion diseases. So prion diseases, just let us quickly go through. So what is prion diseases? Again, it is a neurodegenerative disorder. First point. How it happens? Normally, we have something called as PRP, that is prion protein. That won't cause any problem. But because of this organism, actually prions are infectious protein particles. They are acellular. Am I right? Okay. And these prion particles, this will causes it will convert the normal prion protein into something called as PRPSC. PRP is converted into PRPSC, that is actually called the scrappy protein. This scrappy protein is actually responsible for the pathology. So what is the characteristic feature of this prion disease? It is the spongiform change. Okay, spongiform change, that is there will be swelling of the neurons, okay, and glial cells, and that will be followed by rapidly progressive dementia. There are a lot of diseases which comes under prion diseases, out of which the most important one is Creutzfeldt-Jakob disease, fatal familial insomnia, Kuru disease. Scrappy disease is actually the name of the disease when it occurs in sheep and goats. So what is actually the pathogenesis? I have told we have something called as PRP, okay, and that will be converted into PRPSC. So alpha helix is converted into beta helix. That is responsible, and this, remember, this beta helix or this PRPSC cannot be digested. Okay, it cannot be digested, it cannot be removed by the macrophages. So there will be accumulation of this PRPSC in the neural tissue. That is responsible for some pathological changes, which will cause a spongiform changes in the neuron. There will be swelling of the neurons. That is responsible for this all clinical manifestations. Okay, so you can see here, these are the prion diseases. The characteristically present with rapidly progressive dementia, Kuru plaques and PRPSC protein deposits will be there. The genetic causes mutation of the PRP protein. Okay, that is the alpha helix will be converted into beta helix. Okay, and the patient will be present with what? Rapidly progressive dementia. Then again, coming into Creutzfeldt-Jakob disease, okay, that is actually the same. The pathogenesis of Creutzfeldt-Jakob disease, prion disease, everything is same. Just I want to focus on the morphology. See, remember, there will be brain atrophy, spongiform transformation of the gray and white matter will be present, okay, and this mainly affects, okay, caudate and putamen will be affected, okay, and you can see Kuru plaques, which are nothing else but extracellular deposits of abnormal PRP proteins will be there, which can be stained by Congo red and TAS, both will be positive, and this mainly occurs in cerebellum, okay. And remember, we have something called as a special immunochemical stain, IHC marker, okay. I think this has been a question in an entrance exam. What is that? It is called proteinase K, okay, proteinase K. Here it is also written here, proteinase K, okay. I will write here again. Proteinase K is actually a IHC marker, okay. It's actually an IHC, immunohistochemical marker for prion diseases, okay. It is diagnostic of prion diseases, okay. So with this, we have completed prion diseases also. So in this video, we have covered what are the prion diseases we have covered. Then we have discussed about multiple sclerosis, which is very important. Then HSV encephalitis, neurocephalus, meningitis, okay. Then subarachnoid hemorrhage, okay. So these are all the questions that we have discussed in this video. Thank you.